In this section, we are going to discuss on macrocytic anemias. We already have discussed on various types of macrocytosis in the basics of anemia section, that is megaloblastic macrocytosis and non-megaloblastic macrocytosis. But I'm not going to discuss again in this video just to save the time. So we know there are two classic causes of megaloblastic macrocytosis, that is B12 deficiency and folate deficiency, which is what is going to be of paramount importance in this video. Before going into the B12 and folate deficiency per se, we can see what is the definition of macrocytosis. First, what do you mean by macrocytosis and what is the definition of macrocytosis? It depends on the mean corpuscular volume. So MCV of the RBC, you know that the normal MCV of the RBC is somewhere between 80 to 100 femtoliters. So which means in adults, I'm not talking about like your newborn or infantile population. In a standard adult population, the upper limit of normal of MCV is considered to be approximately around 100 femtoliters. So whenever your MCV exceeds 100 femtoliters in adults, this is what we are going to define as macrocytosis. But your macrocytosis definition actually is a little bit variable according to your age group. There are, for example, in newborn and infantile population, the MCV tends to be a little bit higher physiologically itself compared to the adult population. So that is the reason why it can be adjusted to age also. So for example, in preterm infants, if you ask me what is the definition of macrocytosis, in preterm infants, it is said to be somewhere more than 120 femtoliters, which means up to 120 femtoliters may be taken as normal in case of a preterm infant. And if you have a term newborns, so term, and if you have a newborn population, in a term newborn, typically you can take it as more than 110 femtoliter as upper limit of normal, and you can keep this as a upper limit cutoff for definition of macrocytosis. And in infants and very young children, actually paradoxically speaking, your MCV is a little bit less in this population. So anything more than 90 femtoliters can be defined as macrocytosis in this population. But even though I've told you different cutoffs for different age groups for macrocytosis, but in exams you have to remember only one thing, that is 100 femtoliters. Whenever your MCV exceeds 100 femtoliters, this is what we're going to define as something called a macrocytosis. Standard definition for macrocytosis. So as I already told you, we have two types of macrocytosis. Whenever you call macrocytosis, you have two different types of macrocytosis. One is called a megaloblastic macrocytosis, and second one you have something called a non-megaloblastic macrocytosis. If you want to know the differences between a megaloblastic and a non-megaloblastic macrocytosis, it's actually quite simple. So here you're going to have something called an impaired DNA synthesis. So your DNA synthesis will be impaired. So that is the basic idea of a megaloblastic macrocytosis, impaired DNA synthesis. So because of the impaired DNA synthesis, there will be something called a delayed nuclear maturation. There will be a delayed nuclear maturation. So because of the delayed nuclear maturation, you will have a very high NC ratio in these patients, which means the nucleus will remain persistently bigger. I told you in many of the lineage, especially in the erythrocyte lineage, the nucleus becomes progressively smaller and smaller in size, and the same in the WBC lineage also, the nucleus becomes progressively smaller and smaller in size and becomes very small. In erythroid it's completely expelled, but in myeloid it becomes smaller and smaller in size over time. But here, because of the delayed maturation and because of the poor DNA synthesis also, your maturation will not happen. Because of the same reason, the nucleus will not become smaller in size and the nucleus will remain bigger, and that is the reason why your nuclear cytoplasmic ratio is increased in these patients. Whereas in non-megaloblastic macrocytosis, there is no impairment of DNA synthesis. There is absolutely no impairment of DNA synthesis. But why do you get macrocytosis in a non-megaloblastic causes? We don't know. Really, we don't know what is the real reason why you get macrocytosis in non-megaloblastic causes. But there are some theories are there, like you have something called excessive membrane lipids, probably due to redundant membrane, excessive membrane lipids. That could be the reason for why you get a non-megaloblastic macrocytosis. The classic examples of what you will get in a megaloblastic macrocytosis is vitamin B12 and folate deficiencies. So deficiency of vitamin B12 and folate are classic examples of megaloblastic macrocytosis, even though you have a lot of other causes like myelodysplastic syndromes and all. But traditionally this B12 and folate deficiency are classic examples. Then if you ask me what are the classic examples of non-megaloblastic macrocytosis, I have discussed in detail in the basics of anemia section, but at the same time, most common cause if they ask you, answer must be alcohol. Alcohol is the most common reason why you get a non-megaloblastic macrocytosis. But one more difference if you want to know, in a megaloblastic macrocytosis, the MCV, if you don't treat them, the MCV can exceed even 120 femtoliters in adults. But it never exceeds 120. The non-megaloblastic macrocytosis never going to exceed 120, which means it will be usually approximately in the range of 100 to 110 femtoliters and nothing more than that. So it will not exceed 120. But in a megaloblastic macrocytosis, your MCV can exceed 120 femtoliters as well. So these are some of the basic differences between a megaloblastic and non-megaloblastic macrocytosis. Beyond that, we are going to go into the core of the megaloblastic anemias, that is macrocytic anemias in general, that is the vitamin B12 and folate deficiency, of which the first thing what we are going to discuss is on the vitamin B12 deficiency. So the moment you call about the vitamin B12 deficiency, you have to know about the basics of vitamin B12 and what are the functions of vitamin B12 and what your deficiency is going to mean. That's what we have to know. So first of all, let us see what are the active forms of vitamin B12. So the moment I tell about the active forms of vitamin B12, it is two things. One is your methylcobalamin, and second one is something called adenosylcobalamin. So where your methylcobalamination and adenosylation, that is methyl and adenosyl, are attached, this is what we call activation process. Addition of this methyl to the methylcobalamin and addition of the adenosyl group to the cobalamin, forming adenosylcobalamin, is what we refer to as something called activation process, and that happens in the liver. So which means your only cobalamin is not active form. Your methylcobalamin or adenosylcobalamin is supposed to be the active forms, and that activation is going to happen in the liver. And because this methylcobalamin and adenosylcobalamin are the ones that are going to participate in variety of enzymatic reactions, which I'm going to discuss in some time. So these are the active forms. And number two, what are the sources? The moment if I ask you about the sources, where do you get this B12 from? First one I'm going to call it as an animal product. Animal products. So almost all the animal products have a lot of B12. Exception, the only exception being honey. Honey is a very poor source of vitamin B12. Apart from that, every single other animal products, including milk, dairy products, meat, every single animal product you get are rich sources of vitamin B12. But remember, that is the reason why vegans are at very high risk. Vegans are people who doesn't eat any animal products. Those are what we call as vegans, and that is the reason why these people are generally at high risk for not actually I'm meaning about the vegetarians, I'm talking about the vegans who generally don't consume any of the animal or animal related products itself. So these are the people who are at high risk of developing vitamin B12 deficiency. At the same time, you have dried or fermented plant foods. So you have a lot of dried plant foods or fermented plant foods can have your vitamin B12 in lot of quantities. At the same time, you can synthesize from the intestinal flora. Your intestinal bacteria can also synthesize vitamin B12 on its own. So these are the three major principal products, but as far as I know, the most important is going to be on the animal products. The emphasis is always going to be on animal products that is going to contain a lot of vitamin B12. And where in the intestine, if they ask you the B12 is synthesized by the intestinal flora, it is in the large intestine. It is the large intestine. But what is the catch in this? even though the intestinal flora synthesizes B12 in the large intestine, but actually absorption of your B12 happens in the ileum, isn't it? Absorption of B12 happens in the ileum, which means even though your intestinal flora synthesizes B12, it is useless. It's not going to be of any help because the synthesis happens after the area where the B12 is going to be absorbed, so after the ileum, so that is not going to be of any use. That is the reason why the consumption by diet is what is very important for avoiding the B12 deficiency. So consumption by diet, so important. But the intestinal flora synthesis of B12 is not that important because synthesis happens in the large intestine, which is beyond the area of absorption of B12, which is really in the ileum that is happening. So next, moving on to the absorption process. So how the vitamin B12 is absorbed, because this forms the basis of something called what you do as something called a Schilling test, which I've discussed in detail in the GIT section. But anyway, this absorption process is really important. So let us see how this absorption process really works. So you can see here in this, you're intaking a food, probably let us assume you're taking a animal product related food which contains a lot of cobalamin, but the problem with this cobalamin is attached to the proteins that contain in the food product. So cobalamin will not be separate, the B12 will be attached to the proteins in the food itself. At the same time, your salivary glands are going to secrete something called a haptocorin, that is also referred to as something called R-binder. The other name for R-binder is what we refer to as something called a haptocorin. So both come down, yes, both come to the stomach. So in the stomach, what is going to happen is that, 2 to 3 things that happen in the stomach. The first one, your hydrochloric acid and pepsin, your gastric acid and pepsin is going to remove this cobalamin from the protein. So first, the food product protein will be separated, and your cobalamin, so this is the B12, that B12 also gets separated from the proteins in the food. But the problem with this is, if B12 is separated out, there's a lot of chances this hydrochloric acid can destroy this B12 in the stomach itself. To avoid this destruction by the stomach acid, this B12 is going to mix with your haptocorin, which is already present in the digestive juice, which is already coming via the saliva that you swallow, isn't it? So this B12 is going to mix with the haptocorin, otherwise referred to as something called a R-binder, and they form a complex called B12 haptocorin complex or cobalamin haptocorin complex or B12 R-binder complex, in whatever way you can call. So this cobalamin and haptocorin, once they bind with each other, so they enter the next process. So this is step number 1 I told you that happens in the mouth itself. Step number 2 that happens in the stomach. And in the duodenum, you have step number 3 that happens where your trypsin that is coming from the pancreas will work, and it's going to separate out your R-binder, that is haptocorin, from the cobalamin. So in this condition, the cobalamin is once again separated from the R-binder. This haptocorin is separated out and the cobalamin is separated out. So, but here again the cobalamin is alone, but cobalamin cannot be alone here. And in this area, in the duodenum, the cobalamin, now the B12 is going to be combining with another one, something called an intrinsic factor in the step 3. So this intrinsic factor, he asked me where it is coming from. It is coming from the stomach itself, because your parietal cells in the stomach, the parietal cells in the stomach which secrete the hydrochloric acid, they are also going to secrete the intrinsic factor as well. So this intrinsic factor is the one that is going to bind with the B12, and they form a complex called B12 intrinsic factor complex. That is what we call as cobalamin intrinsic factor complex. Remember, this cobalamin intrinsic factor complex is the one that is absorbed in the ileum. That is typically in the terminal ileum, in the last area of the ileum, in the distal portions of the ileum. That is where your B12 is getting absorbed. So if they ask you where the B12 is absorbed, the answer must be very simple, that is the terminal ileum. But if they ask you where folate is getting absorbed, your answer must be in the jejunum predominantly, in the late part of the duodenum and the jejunum, probably the folate is getting absorbed, but typical answer is jejunum for folate and the distal ileum for B12 absorption. So they are going to be absorbed as a intrinsic factor, and they're going to be absorbed as an intrinsic factor, as well as you can see here is the intrinsic factor and this is the B12, and they're going to be absorbed through a receptor in the terminal ileal cells called a cubilin receptor. Clear? So cubilin receptor. So once inside the terminal ileal cell, inside the enterocyte, once again this intrinsic factor will be separated out from the cobalamin, and this cobalamin will be transported out of the cell by addition of another new protein called as transcobalamin. So this is what we refer to as something called transcobalamin, or simply you can call it as transcobalamin 2, or simply you can even call it as a TC. So once this B12 mixes with this transcobalamin, it is exported out and transferred in the blood as cobalamin and transcobalamin complex. And this is what we called as the active form of B12, because this transcobalamin and B12 complex is the one that is going to supply B12 to the cells. I'll tell you why this point is important. So before going into why that particular point which I told you is important, let us recap what is happening. So you have 4 different steps that is happening. In step number 1, your B12 and is entering into the mouth, and along with that your R binder is secreted. In step number 2, that is happening in the stomach, where your hydrochloric acid is going to separate out the B12 from the proteins that is present in the food, and now the salivary R binder that is coming along with the food is now going to mix with the cobalamin, so which is forming a R binder B12 complex. At the same time, in the stomach, one more thing that is also getting secreted is the intrinsic factor, that is also secreted in the stomach only. But right now it is not important. The intrinsic factor is important in the step 3. In the step 3, which happens in the duodenum, the trypsin separates out the R binder from the cobalamin, and the cobalamin is alone once again, which now combines with the intrinsic factor that is secreted already in the step 2 in the stomach, so forming the B12 intrinsic factor complex. And finally in step 4, which is happening in the terminal ileum, where this B12 intrinsic factor complex is absorbed into the enterocyte through a receptor called cubilin receptor, where inside the cell once again the B12 is separated out from the intrinsic factor, and once again it is mixed with another protein called transcobalamin or transcobalamin 2, or simply you can call it as TC, where it is transported in the plasma as active form of B12. In the sense, I am not calling as active form, like in the sense this transcobalamin B12 is the one that is going to supply your cells that need B12. So why that point is very important? Because the transport form of B12 is of 2 types. The first transport form of B12 we already discussed is in the transcobalamin B12 complex, or simply you can call it as transcobalamin 2 B12 complex. But the problem with this is the one, this form of transport is the one that is going to supply the cells that need B12. But the problem is this contributes only to approximately 20% of the circulating B12. This is not something that is the predominant form of circulating form of B12. This contributes only 20% of the circulating form of the B12, but the most of the B12 in the plasma, in the blood, is going to be circulated in the form of R binder once again. R binder B12 complex, or simply you can call it as haptocorrin B12 complex, both are the same. So this is the one that is going to contribute to 80% of your circulating forms of B12, which means this complex does not supply the cells that need B12, which means they just are transported in the blood, or they're just circulating in the blood, but this is not going to supply the cells that need B12 really. So which means this is not that important, to be honest. So approximately 80% of your B12 is going to be circulating in this form only. So that is the reason why you have certain problems. For example, there are certain conditions like you have a CML, you have something called a fibrolamellar HCC. You would have heard about that in a pathology a lot. We have also discussed a lot in our liver section, fibrolamellar type of hepatocellular cancer, and you have primary myelofibrosis, which we are again going to discuss in detail in the subsequent topics. And you also have a lot of other myeloproliferative neoplasms, we commonly called as MPN. And primary myelofibrosis and CML are also a type of myeloproliferative neoplasms only. Simply I'm telling you. So some examples of these conditions. So these are certain conditions where your haptocorin synthesis will be increased. Your haptocorin synthesis will increase in these scenarios. If haptocorin synthesis is going to increase in these scenarios, what is going to happen is majority of the B12 will be shunted to be binding with haptocorin complex. Very little will be available for binding with your transcobalamin 2. So which means lot of the B12 will be shunted towards a form of transport that is not going to supply your cells that need B12, which means it will result in a functional form of B12 deficiency, and they might result in a megaloblastic anemia as well. So what you get in a B12 deficiency picture, even though the serum B12 if you take and see in this condition will be normal, because the circulating B12 may be okay, even may be increased, but it's circulating in a form which does not supply the cell. So what's the use? So that is the reason it might result in a functional form of B12 deficiency. So that is what is important. In these conditions you might get in a functional B12 deficiency. And there is one more second condition where there is congenital deficiency of transcobalamin 2. Congenital transcobalamin 2 deficiency. So if you have a congenital transcobalamin 2 deficiency, which means there is no transcobalamin at all. In the sense, almost all of the B12 has to circulate in the form of your R binder, that is haptocorin B12 complex only. Even though again in this congenital transcobalamin 2 deficiency, the serum vitamin B12 levels will be typically normal, because majority of the B12 are normally transported with the haptocorin complex only. So here the serum vitamin B12 may be completely normal, but there is no correct form, transport form of B12 available for the cells to supply the cells that need B12. So that is the reason in congenital transcobalamin deficiency, even though the B12 serum in the serum may remain normal, but they will go for fulminant megaloblastic anemia. They'll go for fulminant megaloblastosis. They can go for fulminant megaloblastosis, and the patients typically get severe megaloblastic anemia within 2 months of birth. And if untreated, definitely it is fatal and the patient is going to die for sure. So that is the reason why these two conditions are very important. So condition number one, whatever these two conditions which I have told you, in both the conditions, serum vitamin B12 may be normal, but still the patient will be suffering from severe megaloblastic anemia. Condition number one, where you have a lot of myeloproliferative neoplasms like CML and primary myelofibrosis, and in fibrolamellar type of HCC, where haptocorin synthesis will be increased. Because of that, you will get a functional B12 deficiency. And second one, you have a congenital transcobalamin 2 deficiency. In this condition, also the serum vitamin B12 will be normal, but at the same time, since the form of transport that supplies the cells is not there, so you will get a severe fulminant B12 deficiency within 2 months of birth, and the child also has a lot of possibility of death within the first 2 months if left untreated. So these are some of the applied things about this haptocorin and R binder related thing, haptocorin and transcobalamin 2 transport. So after knowing, so next thing I'm going to discuss now storage of vitamin B12. So how the vitamin B12 is generally stored. So 60% of the storage is seen in the liver, and if they ask you this storage form of vitamin B12, how much time it's enough for approximately 3 to 4 years. 3 to 4 years. And how much the liver generally stores, which means the 60% that is present in the liver contributes to how much thing, it approximately 2 to 3 milligram is the amount that the liver generally stores, that contributes to 60% of the stores, which is enough generally for approximately 3 to 4 years. But there is some difference in the folate, which I'll tell you later on. At the same time, 30% is stored in the muscles. 30% of B12 is stored in the muscles. And what is the importance of this storage form is, B12 is actually water soluble vitamin, isn't it? So B12 is the only water soluble vitamin that is stored in significant forms in the body. But to be honest, if you ask me only fat soluble vitamins are generally stored in the body in significant amounts. The water soluble vitamins are generally not stored in the body in this significant amounts. B12 is the only water soluble vitamin that is stored in significant amounts in the body, that the stores can last even for almost 3 to 4 years. So that is why this B12 storage is very significant as well. And next, moving on to the functions of vitamin B12. So to know about the functions of the vitamin B12, we have to know there are two important types of reactions that contribute to understanding the functions of B12. So I can show in this diagram. So one is this methionine cycle, which I am going to discuss in detail. So this methionine cycle has been put in detail in this particular image. And second one, you have metabolism of this methylmalonyl-CoA. The first one is the form of methionine, and second one for methylmalonyl-CoA cycle. In both these conditions, this B12 is very important. So for example, for the methionine cycle, for forming the methionine cycle, you need a very important form of B12 that is called a methylcobalamin. At the same time, for methylmalonyl-CoA cycle, you need the important form of B12 called as adenosylcobalamin. So that is why I told you this methylcobalamin, adenosylcobalamin are the active forms of B12. That's why this activation which I have discussed already that happens in the liver, this methylated form of B12 and adenosylated form of B12, which is really, really important. That is the thing that participates in these two areas. And so basic understanding. So these are things. So why this methionine cycle is important? So you can see this methionine cycle participates in methionine homocysteine reactions, where you can see this methionine is formed from homocysteine. So this methionine is actually formed from homocysteine. Why this step is very crucial? Because this is the place where you form something called this tetrahydrofolate. Like this is THF formation is there from something called N-methyl THF, which means this methylated form of THF becomes tetrahydrofolate, which is further going to participate in a series of reactions which I will discuss later on. But this N-methylfolate conversion to tetrahydrofolate is very important because there is a transfer of methyl group. So this homocysteine is not having methyl group. So this methyl group from THF transfers this methyl group to the homocysteine molecule, forming methionine. So this methionine as an additional methyl group, that is what is important. So now this methionine becomes something called S-adenosyl methionine, and this S-adenosyl methionine becomes S-adenosyl homocysteine. During this fact, you know very well that this methionine molecule is going to have this additional methyl molecule, that is CH3 molecule, but this homocysteine is not going to have this methyl. So where this methyl has gone? So that is the reason why you can see a substrate, it could be any substrate that becomes a methylated substrate. So this is what we refer to as something called a methylation reaction. So once again this S-adenosyl homocysteine becomes S-adenosyl methionine becomes S-adenosyl homocysteine becomes homocysteine, and the cycle will continue. So which means what you are essentially doing here is you are transferring the methyl group from the folate, that N-methyl tetrahydrofolate, and you are pushing this methyl group to some substrate that is going to get methylated. So that is what is going to called as something called a methylation reaction. So this homocysteine cycle, the entire idea of doing this homocysteine cycle is this methylation process. So where the methyl group from the N-methyl THF is transferred to some other substrate that needs this methyl group. So that is what we called as a methylation reaction. So this is the basic principle. At the same time, it is also important for the metabolism of this odd chain fatty acids, where your degradation of lot of these odd chain fatty acids will result in the formation of something called methylmalonyl-CoA. At the same time, the degradation of lot of amino acids, like you have methionine, valine, isoleucine, threonine, all these things are also going to form this methylmalonyl-CoA. This methylmalonyl-CoA can become this succinyl-CoA. This succinyl-CoA conversion will happen only in the presence of this adenosylcobalamin, which acts as a cofactor as again. And this succinyl-CoA is very, very important for heme biosynthesis, because we already saw in the heme pathways the succinyl-CoA with the addition of glycine forms the heme. Initial ALA, isn't it? That ALA forms the substrate for further entire heme synthesis pathway, which you can see in the previous sections which I have already discussed. At the same time, the succinyl-CoA also enters the TCA cycle, where they can also become a source of energy as well. So this protein breakdown also can become a source of energy for the body. So this methyl-malonyl-CoA cycle, again, it's very important for the body's general metabolism of amino acids as well as the hard chain fatty acids, for which your B12 is once again of paramount importance. So there are two cycles, very simple. One is your methionine cycle. In summary, your methionine cycle is important, where this methionine cycle is important for methylation reactions, methylation of certain substrates. For this, your this methionine cycle is very important. For this, the B12 form you need is something called methyl form of B12, that is called methylcobalamin. At the same time, second set of reaction you need is the methyl-malonyl-CoA cycle. Methyl-malonyl-CoA, so where your odd chain fatty acids, and lot of amino acids like methionine, valine, isoleucine, leucine, all this, isoleucine, threonine, all these things, final end result is formation of methyl-malonyl-CoA, where it can be further degraded only with the help of your B12. Again, that form of B12 you are going to call it as adenosyl cobalamin. So you need methylcobalamin for the methionine cycle, and you need adenosyl cobalamin for the methyl-malonyl-CoA cycle. So both these things are of paramount importance. So these are the important functional activities of B12. Remember, and these methylation reactions are again very important for neurons especially. I didn't tell you that. And that is the reason why the neurological symptoms, are very typical in a B12 deficiency at the same time. So for neurons, again, especially for the formation of myelin, this methylation reactions are very important. The methylated substrates are very important for formation of myelin in the neurons. So you can see all these things. At the same time, if they ask you which is the one that is related to the folate metabolism also, your methionine cycle. So methionine cycle is the one that is related to the folate also. You can see again here, the folate and B12 are related through the methionine and the homocysteine cycle only. So that is also an MCQ in the exam, where they will ask you which cycle, the methyl-malonyl-CoA cycle or the methionine cycle, which is related to the folate metabolism as well. So your homocysteine and methionine cycle is the one that is related to the folate metabolism also, and that is also the one that is going to give rise to something called folate trap, which we'll discuss in some time. So after knowing the functions of B12, let us see what are the etiologies of B12 deficiency. So what could be the reason for getting a B12 deficiency? If you ask me the etiologies of getting B12 deficiency, I can divide into three. First one is the reduced intake, or you can go for malnutrition. And the second one, you can divide into something called reduced absorption of B12. And the third one, you can call it as increased competition or increased demand. Increased competition, or you can put under increased demand case scenarios. So these are the three areas where you can get a proper B12 deficiency. So whenever you ask about this decreased intake or malnutrition, the most important thing is in the alcoholics. Alcoholics are the ones who are generally prone for malnutrition. At the same time, they don't take sufficient B12. And second one, you can get in something called anorexia nervosa, where the patient doesn't take any food at all. And the third one, most important, as what I see in my practice very usually, is the vegan population, which I've told, because they don't take any animal related products. That is the one that poses them at extremely high risk of B12 deficiency. At the same time, when you have reduced absorption, where you can get reduced absorption in pernicious anemia. If they ask you what is the importance of this pernicious anemia is supposed to be the most common cause of B12 deficiency in the Western world, not in India. In the Western world, this pernicious anemia is the most common cause of B12 deficiency, where you have antibodies against the parietal cell and the intrinsic factor. It's an autoimmune condition, which we'll discuss. And next thing, when you have a gastrectomy. So the reason why in a gastrectomy you will have a B12 deficiency is because you will have reduced the secretion of intrinsic factor. Again, intrinsic factor B12 complex is the one that is absorbed in the terminal ileum. That's the reason why in gastrectomies you can get. In spruce, typically in you can get in celiac sprue as well as in tropical sprue, but very common in tropical sprue than celiac sprue. Because in tropical sprue, predominantly the distal part of the intestine is affected, whereas in celiac sprue, the proximal duodenum is predominantly affected, even though both can be affected in both, but this is the scenario. Typically in tropical sprue, the distal ileum is predominantly affected. That is the reason in tropical sprue that typically happens in India, the B12 deficiency is extremely common compared to the celiac sprue. And again, Crohn's disease, like the most common area where you have disease affecting in Crohn's disease is in the terminal ileum. Again, that helps, that explains easily why you get a B12 deficiency in Crohn's disease as well. So whenever you have increased competition and demand, so you can get in something called a SIBO, where you have a small intestinal bacterial overgrowth, where the bacteria that is proliferating the small intestine is going to take up a lot of B12, and they're going to leave very little B12 for absorption. That is the reason, that is due to the increased competition from the bacteria. So that's what we're going to call it as SIBO, small intestinal bacterial overgrowth. Then you can get in a fish tapeworm. Again, it is due to competition, where the fish tapeworm, that is something called Diphyllobothrium latum, which is one of the very important things in parasitology, where if they ask you which of the following worms causes B12 deficiency, answer must be anti anemia, it's hookworm. But similarly, the fish tapeworm is going to cause your B12 deficiency, that is Diphyllobothrium latum. And increased demand happens in pregnancy and in a breastfeeding mother, and when a patient is having a leukemia, where the leukemic cells and the malignant cells are going to have high competition for the B12 because of their very high nuclear proliferation rates. They need B12 for the nuclear maturation, so they're going to consume a lot of B12. So in leukemia, again, because the increased demand, you're going to get a B12 deficiency. So these are some of the things, but more important, what I would try to tell for exams is the vegans population, and next is the pernicious anemia. Then probably could be the SIBO, the fish tapeworm, that's very favorite for the examiners, Diphyllobothrium latum, and probably the tropical sprue. So these are some of the major things that is needed for exams. Other things you might need to remember, but not that important for exams. Then let us see some important note on pernicious anemia. Before going into the details of B12 deficiency, let us see some of the important things about this pernicious anemia also. So what happens in pernicious anemia is, first of all, it's an autoimmune disease. Since it's an autoimmune disease, many times this pernicious anemia will have associated other autoimmune conditions also. You have a lot of associated other autoimmune conditions also, like vitiligo. You might have an autoimmune thyroiditis, like Hashimoto's thyroiditis. A lot of other autoimmune like syndromes may be associated with your pernicious anemia. First thing, that is what is you have to understand. And second thing, it is usually common in females than in males. Obviously, it's more common in females than in males, usually in the ratio of 6:1. And many people think it affects the earlier age group. No, it's not. It typically affects people of approximately 60 years of age. So in exam, don't think that pernicious anemia, if the patient is having 50 or 55 years of age, don't think pernicious anemia is not possible. So typically it happens in the elderly people only. Around 60 years of age is the mean age of population where the people are affected with pernicious anemia. And next thing, it is usually due to the antibodies. So what are the antibodies you have? One is the anti-parietal cell antibodies. So which means these antibodies target the parietal cell. Typically, where in the parietal cell the target is the H plus K plus ATPase. This is the pump that is important for the gastric acid secretion. So they're going to target these pumps only. They are targeted against this H plus K plus ATPase, the hydrogen potassium ATPase, or simply we are going to call this antibodies the anti-parietal cell antibodies. And the second one you are going to call it as anti-intrinsic factor antibodies, which means these are going to bind with the intrinsic factor and prevent intrinsic factor from binding with the B12. So B12 will not be absorbed in this scenario. So these are the two antibodies that are present. If you ask me, what are the other associated conditions? For example, I told you a lot of other associated conditions are there with pernicious anemia. What are the associated conditions? You can have an autoimmune thyroiditis. Like Hashimoto's thyroiditis. Because of that, you might have a hypothyroidism. And second one, people may have a vitiligo. At the same time, apart from the autoimmune associations, patients may have association with something called blood group A. Blood group A's are higher association with this pernicious anemia. Then patients may be having association with something called a gastric cancer, because pernicious anemia itself increases the risk of gastric cancer. That's why I told you that point. Very important for exams as well. At the same time, it is also having association with people who are having blue colored eyes, and this is also having association with people who are going to have premature graying or early graying, and this is also having association with something called hypoparathyroidism, and also this is also going to have association with something called hypogammaglobulinemia. Hypogammaglobulinemia. So these are the associations of pernicious anemia. That's it. So the two antibodies, very important, which I am going to discuss again later on in the investigation section, but very important to know. So these are the associations. So what are the pathophysiology? Pathophysiology of clinical features. The pathogenesis of this B12 deficiency. What are going to be the pathogenesis? If you ask me the pathogenesis of B12, so the two enzymes that are defective in B12 deficiency is one is the methionine cycle enzyme, that is called the methionine synthase. This enzyme is going to be defective because I told you here this enzyme methionine synthase needs this methylcobalamin, obviously. Similarly, you have another enzyme that depends on B12, that is methylmalonyl-CoA mutase for methylmalonyl-CoA cycle. So B12 again is important here. So come back, you can write the second enzyme that is important is your methylmalonyl-CoA mutase. So these are the two enzymes that are dependent on the B12. So here the cofactor, if you ask me in methionine synthase, the cofactor that is important is methylcobalamin, and here you have something called adenosylcobalamin. So this acts as a cofactor. So what happens is this methionine synthase, it converts homocysteine to methionine, and in the process it's also going to convert one more thing that is called a methyl THF to THF. So that's what is going to happen. So if this step is not going to happen, so if there is a block in this step, methionine synthase is not working because B12 is not there, so which means your methionine formation will not happen and THF will not form, which means your homocysteine levels are going to increase. At the same time, this methyl THF cannot transfer this methyl group to methionine to form methionine. So this methionine is the one that is generally carries the methyl group for the methylation reactions. So this methylation reactions, your methionine formation is very important. So methylation reactions also are not going to happen. So this is what is going to happen. So your methylation reactions are going to decrease and your homocysteine levels are going to increase. At the same time, this THF is very important. This THF is the one that transfers the one carbon moiety to produce the DNA, RNA and all, which I'll tell you in some time. So the DNA, RNA and all is very important, which we'll discuss in a separate diagram. So this THF is very important, that is going to form the DNA and RNA by transfer of something called this one carbon moiety, which I'll tell you, because this THF becomes methylene THF, which we'll see in the folate metabolism, and that methylene THF is the one that is going to transfer the one carbon moiety to produce this DNA and RNA. So the DNA, RNA is also going to decrease. So because the DNA and RNA are decreasing, it's going to result in something called defective DNA synthesis. I told you, that's what, impaired DNA synthesis. That's the reason for this megaloblastic anemia, impaired DNA synthesis, and that is the reason why you have this poor nuclear maturation in the bone marrow. Defective DNA synthesis and poor nuclear maturation in the bone marrow, and that is the reason why you get this anemia, and in fact even you can get a pancytopenia, because it's not going to affect only the RBCs, it's going to affect the myeloid lineage cells as well, other myeloid lineage cells as well, and even the lymphoid lineage cells. You might result in a pancytopenia because of the poor nuclear production and maturation over time. At the same time, this increased homocysteine levels also predisposes the patient to excessive cardiovascular risk. You know very well this hyperhomocysteinemia or increased homocysteine levels is very heavily atherogenic, and is going to participate in formation of MI, stroke and a lot of other atherosclerotic complications. So definitely this is going to predispose to a very high cardiovascular risk. At the same time, whenever you have a defective methylation, so you have a low methylation, defective methylation, whenever you have a defective methylation, that also predisposes to something called demyelination. So I told you this methylation is very, very important for the formation of myelin, because a lot of myelin related proteins are methylated. So if you don't have that, you are going to result in a demyelination as well. At the same time, in a methylmalonyl-CoA mutase, I told you, so this methylmalonyl-CoA mutase does one very important thing, that is it converts the methylmalonyl-CoA to succinyl-CoA. So succinyl-CoA, and for that you need this methylmalonyl-CoA mutase enzyme, and B12 is a very important cofactor, and if it doesn't happen, for example, this conversion will not happen and succinyl-CoA production will definitely decrease. At the same time, the methylmalonyl-CoA levels will increase for sure. So this methylmalonyl-CoA levels that are increasing, so usually it might result, because this methylmalonyl-CoA is an acid. So since it's an acidic in nature, the pH might decrease. So these patients may have a borderline decreased pH, usually called as a methylmalonyl-CoA acidemia. Usually typically happens in congenital, when B12 deficiency, seeing acidosis is very, very rare. Only in congenital deficiency of methylmalonyl-CoA mutase, you might have a methylmalonyl acidemia. But in B12 deficiency, you might see, but this is very, very rare. But more importantly, this excessive methylmalonyl-CoA is shunted to produce something called a propionyl-CoA. So what is the importance of this excessive propionyl-CoA formation? So this excessive propionyl-CoA might replace, this propionyl-CoA will replace acetyl-CoA in the neuronal membranes. In the neuronal membranes, because neuronal membranes do contain acetyl-CoA, and this excessive propionyl-CoA will replace this acetyl-CoA in the neuronal membranes. Once it replaces acetyl-CoA in the neuronal membrane, that is going to result in either demyelination, one more reason for why you get a demyelination. At the same time, you might get a axonal injury also in the peripheral nerves. Axonal injury also in the peripheral nerves, which is again of very, very paramount importance. So demyelination and axonal injury, both are due to this excessive methylmalonyl-CoA, which is going to produce excessive propionyl-CoA, and that propionyl-CoA is going to replace the acetyl-CoA in the neural membranes, resulting in neuronal injury, membrane injury, causing demyelination and axonal injury. So these are some of the important pathophysiological point of view that are very important for understanding in terms of B12 deficiency. So if you ask me what are the clinical features that you might get in a B12 deficiency, the clinical features that you may see in a B12 deficiency is, number one is anemia, or you can even get a pancytopenia also. Pancytopenia. And many of the textbooks will give this anemia may be associated with a mild jaundice in these patients. Especially there will be increased unconjugated hyperbilirubinemia. Many people do ask me why you get a jaundice in case of a B12 deficiency. What is the reason association? It is very simple. This anemia, if you ask me why the reason for this anemia is ineffective erythropoiesis. Because of the defective nuclear maturation, you're going to have ineffective erythropoiesis. This ineffective erythropoiesis obviously is going to result in excessive hemolysis within the marrow itself, and that is what is going to cause a mild jaundice, as simple as that. That is due to ineffective erythropoiesis, which we've been discussing in a lot of great detail in the last sections on thalassemia and other hemoglobinopathies. So number one. And second thing, the patient will have neurological complications. So more importantly, there are typical neurological complications if they ask you. One is demyelination in the spinal cord. The patient will result in demyelination in the spinal cord. That happens generally late, demyelination in the spinal cord. Demyelination in the spinal cord will typically result in something called SACD, that is called subacute combined degeneration of the spinal cord. Remember, they produce demyelination in the spinal cord. At the same time, apart from producing demyelination in the spinal cord, they can also produce something called axonal form of peripheral neuropathy. Axonal form of peripheral neuropathy. This is again very, very important, because many students think it's a demyelinating form of peripheral neuropathy. No, B12 deficiency causes central demyelination, that is in the spinal cord, along with that peripheral axonal form of neuropathy, not demyelinating neuropathy. Very, very important. So they produce axonal form of neuropathy. So what is the form of axonal form of neuropathy is typically this pins and needle sensations. Pins and needle sensations, and like patient might get a little bit of coldness coldness, typically they will get in the lower limbs. And this is said to be the most common neurological symptom in B12 deficiency. Remember, axonal forms are length dependent. I told you, we have discussed in neurology already, that is length dependent. Axonal forms are length dependent, isn't it? So that is the reason why the longer fibers, that is the lower limbs, are generally affected. So we are going to again discuss in great detail in neurology. But anyway, so they are length dependent. So the longest nerves are generally found in the legs only. So that is the reason why they are affected first. So there you will get pins and needles and cold sensation probably in the lower limbs. And typically in subacute combined degeneration means they are going to result in something called demyelination. So which areas they will produce demyelination? Demyelination typically affects two columns. One is the posterior column. See, you can produce demyelination only if the tracts are heavily myelinated. What are the two heavily myelinated tracts? One is the posterior column and second is the corticospinal tract. So these are the two columns that are heavily myelinated. So the demyelination will happen only in these two columns probably, plus or minus maybe in the spinocerebellar tract. But that is also a little bit heavily myelinated tract, but that is not that important. But more importantly, this posterior column and the corticospinal tract is very important. So whenever posterior column is affected, you are going to result in loss of vibration. Then you are going to result in loss of tactile localization and discrimination, which is one of the very important, especially this is what we call light touches in the tactile localization. So this is also lost. And probably patient will be losing something called joint position sense, and patient will have proprioception loss, especially the conscious proprioception part, proprioception loss. At the same time, because of the loss of proprioception, patient may have positive Romberg's. And because the posterior columns are affected, I told you one of the important signs of affecting the posterior column is patient may have a positive Lermit sign. There are a lot of reasons why you might get a Lermit sign. Lermit sign is whenever you forcibly flex the neck down, you will have an electric shock-like sensation that is passing down the spine. That is what we call Lermit sign, or simply referred to as Barber chair sign, which I have discussed in neurology again. But in this condition, what is more important is the fact that this Lermit sign may also be seen in B12 deficiency, that is in the subacute combined degenerative score, because they affect the posterior column, not because it's seen in B12 deficiency. Because they affect the posterior column, you get Lermit sign. Anything that affects posterior column, you might get a Lermit sign. So all these things are possible. And similarly, when the corticospinal tracts are affected, you might result in something called a spastic paraplegia or a spastic paraparesis. And again, typically they affect the lower limbs more often, so that is what we called as like spastic paraparesis, and this also can happen. Because the corticospinal tract are affected, patient may have a positive Babinski also, Babinski positive. So that is nothing but extensor plantar. All these things are possible with B12 deficiency. Again, one of the important causes, because B12 deficiency, I told you, can cause demyelination in the spinal cord as well as axonal peripheral neuropathy. Because of the peripheral neuropathy and the damage to the axons that supply the lower limb, you might result in, because axonal neuropathy is typically LMN, you might result in loss of ankle jerk. Loss of ankle jerk is possible. At the same time, because of the corticospinal tract damage, which is typically UMN, you might result in extensor plantar also. One of the very, very important causes of extensor plantar with absent ankle jerk, very, very important, that is SACD. You have Friedreich ataxia, HIV, myelopathy, neuropathy, a lot of other causes of loss of ankle jerk with extensor plantar is there, but nothing is as classical as B12 deficiency, where it produces SACD and produces UMN type lesion causing an extensor plantar. At the same time, it produces LMN type of lesion due to axonal peripheral neuropathy causing your loss of ankle jerk. So this loss of ankle with extensor plantar, always think about SACD as the first possibility in exam. Apart from that, you have a lot of other causes which I have discussed already in neurology. So these are some of the important things that you have to know. So first is the hematological picture, where you get anemia or pancytopenia with little bit mild elevation, unconjugated bilirubin. At the same time, you get a variety of neurological manifestation. Typically 3 things if you want to know: axonal type of neuropathy and subacute combined degenerative of the spinal cord. In the subacute combined degenerative of the spinal cord, 2 tracts are predominantly affected. That is the posterior column, which is going to affect the light touch, vibration, joint position and proprioception with positive Romberg's and loss of joint position. At the same time, corticospinal tract is going to be affected, which might result in spastic paraparous, and final nail in the coffin is the loss of ankle jerk with extensor plantar. Very peculiar combination. And patient may also get psychiatric disease, but the reason why it produces psychiatric disease is really unknown, but probably due to methylmalonyl acidemia, excessive methylmalonic acid, and substitution of the acetyl-CoA on the neural membranes with propionyl-CoA is thought to be the reason for the psychiatric disease, which might result in dementia also, not only psychiatric disease, dementia, depression, paranoid psychosis. Lot of things can happen in B12 deficiency as well. So these are the three things. First is hematological, second is neurologic, third is psychiatric. All these three things are very important in terms of when it comes to the B12 deficiency. The next thing what you have to know is on the diagnosis. How will you make a diagnosis? Through investigations. Diagnosis number one, first thing I'm going to see is on the peripheral smear. So what will I see on the peripheral smear? The classic is defective nuclear maturation and typically seen in the neutrophils. So you are going to see something called hyper-segmented neutrophils. Hyper-segmented neutrophils. So what do you mean by hyper-segmented neutrophils? Actually, there are a lot of definitions for hyper-segmented neutrophils, but typically in exam you can write more than 5 lobes. If the neutrophil nucleus has more than 5 lobes, you call it as hyper-segmented neutrophils. But to be honest, there are some definitions for hypersegmented neutrophils. If there are more than 6 lobes, 6 or more lobes in just one neutrophil, definitely that's a hypersegmented neutrophil. 6 or more lobes, even a single neutrophil is suggestive of a hypersegmented neutrophil. And next thing, more than or equal to 5 lobes in at least 5% of the neutrophils. So this is also definition of hypersegmented neutrophil. So that is the reason I told you in exam, which is more specific is when you have 6 or more lobes in even a single neutrophil. That is why I told you more than 5 lobes is the standard definition. That is 6 or more lobes in neutrophil is a standard definition for something called hypersegmented neutrophil. So if you want to see where is the hypersegmented neutrophil, you can see this picture. In this picture you can see this one. This is an example of a hypersegmented neutrophil where you can see almost, I think, 7 lobes in this. So definitely this is a characteristic example of a hypersegmented neutrophil. This is a hypersegmented neutrophil. At the same time, you have something called defective nuclear maturation. This is a bone marrow picture. Even we don't do generally bone marrow for B12 deficiency, but still if you want to know what you see in the bone marrow, this is what we refer to as something called defective maturation, which means you are going to see a lot of immature cells. You can see promyelocytes, myelocytes and band forms that are not maturing towards the neutrophils, and they are getting accumulated within the bone marrow and they will be destroyed over time. So this is what is going to happen in B12 deficiency, defective maturation. And other investigations what you can do in B12 deficiency is RBC indices. I told you typically MCV will be more than 100, there will be increased MCV, but I told you in a B12 deficiency, untreated B12 deficiency in megaloblastic, it can reach as high as 120 femtoliters also. So MCV more than 100 is very typical. At the same time, patient will have a increased MCH, that is called hyperchromic RBC, mean corpuscular hemoglobin. Even though the hemoglobin overall is decreased, but per RBC your hemoglobin content will be high. It's very peculiar. Again, increased MCH, hyperchromic. At the same time, patient will have normal MCHC. Concentration will be normal because of the size of the cell is high, so the concentration may be normal. So MCHC will be normal, and red cell distribution width will be increased, which is again due to anisopoikilocytosis because of ineffective erythropoiesis. So these are the standard things that you have to know. At the same time, you can do serum third. This is the second one you have done, RBC indices. And the third one, what you can do is something called serum vitamin B12 testing. Obviously, this will be decreased. Serum in vitamin B12 testing will be decreased. And you can, for localization, fourth one, you have to localize, identify the cause. What could be the cause? Identifying the cause. So what could be the cause? So if you want to know the cause of B12, so there are certain investigations which you can do. Number one, you can do something called testing for pernicious anemia. Testing for pernicious anemia. I told you to test for pernicious anemia, you need two antibodies. Number one is anti-parietal cell antibody. This anti-parietal cell antibody has high sensitivity but low specificity. And second one, you have something called anti-intrinsic factor antibody. So this anti-intrinsic factor antibody is the most important. So this is what is preferred testing, to be honest, where because this has very high specificity, even though at the expense of little drop in sensitivity, but this is a very highly specific test, anti-intrinsic factor antibody. Other test to localize and identify the cause, you can do something called Schilling test. It's a series of multiple tests we do at various stages, which I have discussed in detail on the GET section. You have something called a Schilling test. So that is for localization predominantly. Where is the problem? Localization. So other associated findings, if you ask me what you will see in B12 deficiency, that is one is your increased homocysteine. Remember, this increased homocysteine can happen in both folate as well as B12 deficiency, so it is actually quite non-specific for B12 deficiency. But there is another one called increased methylmalonic acid. Increased methylmalonic acid. So this increased methylmalonic acid is actually quite specific for B12 deficiency because this happens only with B12 deficiency. This does not happen with folate deficiency. Why I am telling is because your homocysteine cycle is the one that is related to the folate cycle as well. The folate metabolism and B12 metabolism are linked with the homocysteine cycle only. It's not linked with the methylmalonyl CoA cycle. So that is the reason why this methylmalonic acid increase is very specific for B12 deficiency rather than folate deficiency. But increased homocysteine can happen in variety of causes, including both B12 as well as folate deficiency. And the third one, you can see increased serum gastrin levels. Increased serum gastrin levels. Why you see increased serum gastrin levels? Suppose if the B12 deficiency is due to pernicious anemia. It's not seen in all the cases, but if the B12 deficiency is due to pernicious anemia, you might have increased serum gastrin. Again, if you want to know why serum gastrin is increased, because pernicious anemia is going to result in something called atrophic gastritis. This atrophic gastritis is going to result in increased serum gastrin, because in atrophic gastritis your hydrochloric acid secretion will increase because of the feedback of the decreased HCl. Your serum gastrin will increase. So increased serum gastrin with B12 deficiency, if they ask you, answer must be your pernicious anemia in exam. So it's a very important topic in exam. So they don't give directly as pernicious anemia, they will give just a patient who is having high serum gastrin levels with probably indigestion features and patient is having anemia and B12 deficiency. So what could be the probable cause? Answer must be pernicious anemia. As simple as that. So these are the other associated findings. But most important, the take home, where is your money in exams, is in these two areas. Increased homocysteine and increased methylmalonic acid, but more specific is the methylmalonic acid, which is raised only in B12 deficiency, not in folate deficiency. That's where money is in exam. Then you can go for the treatment. So what you're going to do for the treatment of B12 deficiency. So if I ask you about the treatment of B12 deficiency, typically you have two protocols. One is the IM protocol and second is the oral protocol. Remember, currently both oral as well as IM protocols are effective, but the older textbooks will give IM as the important thing about B12 deficiency, but oral protocols are as effective as IM protocol. Generally what I generally do is oral 2 milligram of B12 daily. Like that's what I prefer in my practice. I generally, even now I give oral B12 only. I don't give IM B12 because I generally don't like that much of injection. So that's the reason. So 2 milligram of B12 daily is more than enough for correcting the B12 within 1 to 2 months. Must be enough. IM protocols, if you ask me what is the IM protocol, typically we give 1 milligram IM B12 for 7 days. Then for the same 1 milligram of IM B12. So here you will give daily B12 IM for 7 days. Then one same IM 1 milligram IM B12 will give weekly now. After this we'll give shift to weekly doses for 4 to 8 weeks. Then you have to give monthly doses. Then every month I'll give the same 1 milligram IM B12 for lifelong. So it's very simple. First give a daily 1 milligram IM B12 for 7 days, then give weekly IM B12, same 1 milligram dose every week for 4 to 8 weeks, then give a monthly 1 milligram IM B12 injection for entire life. So this is the traditional protocol for B12 correction, but even oral protocols are as effective as IM protocols. Remember, one more important thing is the neurological abnormalities will reverse only if B12. Only if B12 is given, neurological abnormalities will reverse only with B12. B12 only can reverse the neurological abnormalities. Suppose if they ask you, what if you give folic acid, folate supplementation, folic acid in B12 deficiency. In B12 deficiency, if you give folic acid, what will happen? It will correct anemia. It's going to correct the anemia, but it will worsen the neurological manifestations. This is a very important point. So folate in B12 deficiency is not warranted. It's going to actually worsen the neurological problems, but it can still correct the anemia. So that is the reason why you have to be very sure that it's a B12 or a folate deficiency. So if you miss your B12 deficiency and if you give only folate in a B12 deficiency, your neurological symptoms will worsen and the patient might even go for complete quadriplegia also. So there's a lot of possibility. But anyway, so why this happens? Because of some principle called a folate trap, and you have to understand the folate metabolism as well. So this diagram will explain you the folate metabolism. So you can see where the folate and the B12 are interlinked is with the methionine cycle. So the methionine cycle is the one. I told you the methylmalonyl-CoA and the methylmalonic acid cycle is not going to relate to the folate cycle. The methionine cycle is the one that is going to be related to the B12 and the folate with each other. You can see where clearly in the methionine synthase step where you need an B12 as a cofactor, that is methyl B12. Methylated form B12 is important for this step. The methionine synthase step where this homocysteine is converted to methionine. At the same time, I told you there's one more thing that is happening. This methyl THF is getting converted to tetrahydrofolate. This is very, very important for replenishing the stores of tetrahydrofolate, because if you don't replenish the stores of tetrahydrofolate, lot of things are not going to happen. So I'll tell you why you get anemia in a B12 deficiency. First, I didn't explain you that at all. So why you get anemia? So in a B12 deficiency, methionine synthase will not work, which means homocysteine to methionine conversion will not happen. So the homocysteine levels are going to increase and methionine is going to decrease. If this methionine is formed less, I told you this methyl group will not be released and your methylation reactions will not be possible. So the methylation reactions also will decrease, and this is the main reason why you get a neurological problem, isn't it? This is the main reason why you get neurological complications in B12 deficiency. Yes, fine. Similarly, in folate deficiency, because the same reason you get, like your neurological complications. Similarly, in folate deficiency, you don't get neurological complications for the same reason, because this folate is no way related to this, like methylation reactions. B12 only is important for the methylation reactions, and that is the reason why folate deficiency generally does not result in neurological complications, to be honest. But both B12 and folate are related to anemia and hematological problems. How? So because I told you, when there is no B12, your tetrahydrofolate levels will also drop. At the same time, when the folic acid levels are low, similarly your again tetrahydrofolate levels will be low only. So why these tetrahydrofolate levels are very important? Because this tetrahydrofolate acts as a carrier for again 1-carbon moieties. For example, you have an enzyme called serine hydroxymethyltransferase. This is called as serine hydroxymethyltransferase, where the 1 carbon, a single carbon moiety from this serine is going to be transferred into the folic acid, that tetrahydrofolate, forming something called a methylene THF. So this is what is going to carry the 1 carbon moiety from the serine amino acid, and it's going to transfer this 1 carbon moiety into a lot of other areas. So the 1 carbon that is coming from this serine, which is transported via which is carried by this THF in the form of methylene THF, has 3 branching divisions. Are there. For example, it can be converting back to something called dihydrofolate. For this, you need an enzyme called thymine-late synthase, where you are going to produce thymine and you are going to synthesize DNA. So this one carbon is transferred to produce the DNA, the structure of the DNA, carbon of the DNA. At the same time, this one carbon that is in the form of methylene can move to form something called formyl THF, where it carries this one carbon and it will be translated to produce adenine and guanine, again which is important for synthesizing the DNA RNA. Again this one carbon is translated into DNA and the RNA. At the same time, this methylene THF can become methyl THF, where this one carbon is translated to form something called methyl THF here, where this one carbon from the methyl THF is the one that is going to be participating in the methylation reactions as well, to be honest. So the one carbon that is carried from the serine molecule is going to be translated into three different branching out pathways. One to produce DNA in the form of thymidylate synthase step, where this methylene THF is converted to something called dihydrofolate. And second one, it can also be translated to produce DNA and RNA through the formyl THF step, and or it can be translated to produce your methyl THF, where it combines with the B12 metabolism and is going to produce methylation reactions through the methionine cycle. So three branching out pathways are there from the methylene THF. That is why this tetrahydrofolate formation is also quite important. So whenever you don't have this folic acid, for example this tetrahydrofolic acid, the tetrahydrofolate is in less quantity, what is going to happen is your methylene THF formation will not happen. If your methylene THF formation will not happen, your formyl THF and your thymidine synthesis, adenine guanine synthesis, nothing will happen. So you'll have a defective DNA and RNA synthesis. So that is the reason why you're going to get something called a poor nuclear maturation. You're going to get a poor nuclear maturation, and because of that only you result in hematological problems like anemia and pancytopenia. Same, like in B12 also, because of the defective B12, again you are going to result in reduced replenishment of this tetrahydrofolate, and the same anemia and all these things can happen. But remember, B12 deficiency only will affect the methionine cycle. If you have a folic acid deficiency, you are not going to affect the methionine cycle if B12 is still there. So that is the reason folic acid rarely gives rise to neurological complications. Only B12 will give rise to neurological complications. So again, which is very important. So if you give folic acid in a B12 deficiency, what will happen? Suppose let me assume I am replacing the tetrahydrofolate. So I am giving excessive folic acid and I am giving sufficient amount of tetrahydrofolate, which means in the B12 deficiency, your tetrahydrofolate is also less. That is the reason why you are getting a anemia. So if I am giving folic acid in a B12 deficiency, your tetrahydrofolate will be replenished, will become okay now. So your methylene THF forming formyl THF and thymidine, all the steps will start happening, but this methyl THF will form, but it cannot become tetrahydrofolate, and this step will still not happen because B12 is still not intact. So that is the reason this is what we refer to as something called a folate trap, where even in the presence of sufficient folate, your methyl THF cannot get converted to tetrahydrofolate, and you need high dose of folic acid continuously to be supplemented to correct the hematological abnormalities in B12 deficiency. So, but that is not the case. If you give B12, everything will settle. So that is what the idea is here. But the folate will not correct the neurological complications because without B12, this methionine cycle will not happen anyways. So that is why, if they give megaloblastic anemia, that is the reason why if they give megaloblastic anemia with your neurological complications, go for B12 deficiency in exams. Similarly, if they give megaloblastic anemia without neurological complications, go for folate deficiency in exam. Folate deficiency in exam. Very, very important. And remember, in B12 deficiency, there will be both increased homocysteine as well as increased methylmalonic acid. Increased methylmalonic acid will be there. Whereas in folate deficiency, there will be only increased homocysteine with normal methylmalonic acid. With normal methylmalonic acid. Very important point, all these things. In a nutshell, you know very well this folate is a very important cofactor. This is the function of the folate. Folate is a very important cofactor for transfer of one carbon moiety. One carbon moiety, this is very important for DNA, RNA formation. At the same time, this is also very important for transferring the methyl group for methylation reactions through B12. Methylation reactions. For forming DNA and RNA, your B12 is not important, but for forming methylation reactions, your B12 is important. So because of this only you will get a neurological complication. Because of this only you are getting a hematological abnormalities. So whenever your transfer B12 is not there, you will result in neurological complications as well as hematological complications. But if your folate is not there, you will result only in hematological complications, but neurological complications is generally not a possibility, because I have explained in detail about all this in the cycle which I have told you already. So this is what we call it as a folate trap, and that's what we, like why you should not supplement with folic acid in a patient with a B12 deficiency. This is a very traditional question, but has absolutely no zero clinical value, because anyone who goes for megaloblastic anemia, we are going to give B12 obviously. Yes. And what is the active form? Now coming back to the folate, finally, this is the final thing. So coming back to the folate. So come back to the folate, if you ask you active form of folate, that is the tetrahydrofolate. From here only everything branches out. You're going to form the methylene THF and everything works here. So because your methyl THF through B12 forms tetrahydrofolate, at the same time from the tetrahydrofolate only you form methylene THF, and all the 1 carbon reactions branch out from here only. So tetrahydrofolate is the one that is the active form. Who's forming the active form of tetrahydrofolate? There are two enzymes that form the active form of tetrahydrofolate, that is active form of folate, that is tetrahydrofolate. One is through the DHFR, that is dihydrofolate reductase, where you have a dihydrofolate forming tetrahydrofolate. And second one who's going to form this tetrahydrofolate is from the methyl THF. Methyl THF, and for this you need B12. For this you need B12 through step called methionine synthase step, which we discussed all through methionine synthase. Methionine will get converted to homocysteine. Homocysteine will get converted to methionine. At the same time, this methyl tetrahydrofolate will get converted to tetrahydrofolate. So these are the two principal forms of tetrahydrofolate in your body. So these are the active forms. Next, what are the sources? Sources means only one thing you have to remember for tetrahydrofolate, that is the greens. Greens form a huge chunk of source of tetrahydrofolate. And very small amounts are synthesized in the intestinal flora also, but that's not important. But the greens, the green vegetables, that's what the massive source of folate in the body. Then absorption wise, if they ask you, absorption typically happens in the jejunum, which, as I already told you, the most distal parts of the duodenum and the jejunum, but jejunum is the most important. Jejunum is the classical area. So where you have some specific transporters in the jejunum that absorb folate. And finally transport, you have something called FBP. These are called as folate binding proteins. Those are the ones that transport the folate, but to an extent it's also bound to the albumin, but very less. Very weak binding to the albumin is also there. Albumin binding is generally weak, but predominantly they are transported in the form of something called FBP, that is folate binding proteins in the blood. So this is how they are going to transport. And storage wise, this is a very important difference from B12. Storage wise, if they ask you, liver is the principal form of storage. Approximately 10 to 12 milligram of folate is generally stored in the liver, which is enough for approximately 3 to 4 months. But remember, B12, the amount that is stored is only 2 to 3 milligram, but that is enough for 3 to 4 years. But here it is stored higher, actually 10 to 12 milligram is stored, but it's enough only for 3 to 4 months. So the folate storage pool is actually quite less, quite less in duration compared to the B12 deficiency, where the stores are sufficient for 3 to 4 years there, but here it's only sufficient for 3 to 4 months. And again, function wise, if you ask me, already I discussed in detail, it is nothing but the transfer of 1 carbon moieties. This 1 carbon moieties is important for the formation of DNA and RNA. At the same time, this 1 carbon moiety is also important for the methylation reactions through B12 and homocysteine cycle. So in all these steps, this 1 carbon moiety, it serves as a transport of this 1 carbon moiety to other areas in the cell. So that is why this folate is very important. And if you ask me the etiology, again, etiology of folate deficiency, etiology wise, if you ask me, it might be due to malnutrition as I already told you, in anorexia patients, alcoholism, which I've discussed already, or it could be due to reduced absorption, which can happen in sprue, celiac as well as tropical sprue, but here both tropical and celiac can cause, because it's in the jejunum is the absorption. Celiac affects the duodenum predominantly, tropical sprue affects the distal ileum predominantly, but since it's in the jejunum, both celiac and tropical sprue has a chance of causing folate deficiency. And big small intestinal dissections, like a huge amount of small intestine in short bowel syndrome also you might get folate deficiency as well as B12 deficiency because of shortened intestine. So impaired metabolism. Impaired metabolism means your folate metabolism is impaired, where typical example is methotrexate or pyrimethamine, or you can get in trimethoprim, where all this have effects. Very important is the methotrexate here, where you have problem in they affect the DHFR, isn't it? So you don't have the folate, that active form of active form that is THF cannot be formed if methotrexate is there. So that is the reason why methotrexate can also result in a functional folate deficiency. At the same time, increased requirement can be there. Very important, this increased requirement. In that, very important point is the chronic hemolytic anemias. In any chronic hemolytic anemias, the requirement of folate increases. That is because the increased RBC turnover, very important. That is the reason why folate supplementation is mandatory in any chronic hemolytic anemia. The stores are also going to manage for a very short time. That is the reason why in chronic hemolytic anemias, giving folic acid is extremely important. Then apart from chronic hemolytic anemia, pregnancy, where there is folate deficiency may result in high risk of neural tube defects, and you might see in a lot of malignancies, patients taking for dialysis, all these patients need a lot of folate because folate is lost in the dialysis circuit as well. So that is the reason. So these are the etiologies of folate deficiency. Clinical feature wise, if you ask me, obviously I told you will see all the features of megaloblastic anemia, all the hypersegment neutrophils, panceribine, everything can happen, but remember there is no neurological manifestations. You don't get neurological manifestations with folate deficiency. B12 is intact, you don't get really. And next thing, you can see the diagnostic point of view. Diagnosis wise, if you ask me, the serum folate will be reduced, but this is non-specific because serum folate only tells you that particular day's dietary intake of folate. It's not going to reflect the actual folate levels in the body. It's only going to depict the blood folate levels, which is again dependent on how much folate you have taken in the recent times, maybe in the last 6 to 24 hours. But it's not going to reflect the real folate deficiency. That is why it is non-specific. And second one, reduced RBC folate. And this is what is very important. This is really specific but not done very commonly. Reduced RBC folate, which typically tells you the tissue folate level, so which is actually quite specific for folate deficiency. And third one, increased serum homocysteine. Very important, but remember, but this is again non-specific because it can happen in folate, say B12 deficiency also. But the patient will have predominantly normal methylmalonic acid levels. If it's a true folate deficiency only, that is what is going to differentiate a folate from B12. If there's a combined deficiency, methylmalonic acid can also be increased. But it's a true folate only deficiency, you will not get a excessive methylmalonic acid, there will be normal methylmalonic acid only. And how you treat? Finally, the treatment wise, if you ask me, it's very easy. Typical dose supplementation is folate 1 to 5 milligram per day. Replacement, oral tablets only. There's no IM folate. We are going to give oral folate only. But typical my standard clinic practice is giving 5 milligram folate, but books will tell you 1 to 5 milligram varying doses, but I will generally prefer 5 milligram per day dose for 1 to 4 months or until complete hematological recovery, because there is no neurological complications. Hematological recovery. Please, when you have a megaloblastic anemia with neurological features, don't give folic acid as an isolated thing because it's going to worsen the neurological features which I have already discussed. So if you have only a megaloblastic anemia without any neurological features, you can go for folate replacement because that is likely to be a folate deficiency, and you need typically 1 to 5 milligram per day of folate for 1 to 4 months or until complete hematological recovery, where you don't see any anemia. At the same time, you don't have any immature neutrophils with hypersegmented nucleus. So this is all about your B12 and folate deficiency. We have discussed in great detail about the pathophysiology and all these things. It's a very important topic. In the recent past, they asked a lot of questions on B12 and folate deficiency. That's why I covered in great detail on this topic. And let us move on to the next topic, that is on the bone marrow failure syndromes.